Hello and welcome to another Froten Academy video. This video is about thyroid function tests. The learning objectives include a summary of the thyroid anatomy and physiology, how thyroid hormones are synthesized and regulated, as well as indications for testing, discussion of the analytical methods, interpretation of the laboratory results, and analytical interferences that may affect the results. The thyroid gland is the first endocrine gland to develop and is located in the inferior anterior neck. It has two lateral lobes on either side of the trachea which are joined together by a connecting tissue known as median isthmus, giving it a bow tie shaped appearance. The thyroid gland has two types of secretory cells. The follicular cells that produce iodine-containing hormones such as tetraiodothyronine and triiodothyronine, and the parafollicular cells, also known as the C cells, that produce calcitonin. Calcitonin is involved in the regulation of calcium in the body and is therefore not the focus of this video. The name tetraiodothyronine or T4 and triiodothyronine or T3 refer to the number of iodine atoms incorporated into each of these hormones. Thyroid hormones affect almost all cells in the body and primarily regulate metabolic rate, which is critical for growth, differentiation, normal nerve development, and function. Synthesis of the thyroid hormones is initiated by the release of thyrotropin-releasing hormone or TRH from the hypothalamus, resulting in the stimulation of the anterior pituitary gland to secrete thyroid-stimulating hormone or TSH. TSH then binds to its receptors on the thyroid gland and stimulates the secretion of primarily thyroxine or T4 but also triiodothyronine or T3 to a lesser extent. Upon stimulation, the endoplasmic reticulum of the thyrocytes produce thyroglobulin, a precursor molecule which is packed into vesicles by the Golgi apparatus and secreted into the follicular lumen through exocytosis. Iodide uptake in the thyrocytes is increased by the protein kinase A, which also activates thyroid peroxidase enzyme or TPO. This enzyme oxidizes iodide to iodine and links the iodine atoms to the tyrosine residue of the thyroglobulin. This results in the formation of monoiodotyrosine and diiodotyrosine depending on the number of tyrosine residues of the thyroglobulin linked to the number of iodine atoms. These iodine-linked tyrosine residues are then joined together by the thyroid peroxidase enzyme via coupling reaction forming tetraiodothyronine and triiodothyronine. Joining of two diiodotyrosine results in the formation of T4 or thyroxine, and joining of a monoiodotyrosine to a diiodotyrosine results in the formation of T3 or triiodothyronine. Whilst all thyroxine or T4 is produced in the thyroid gland, only about 20% of T3 is secreted directly from the thyroid and the majority is formed in the peripheral tissue, primarily in the liver, by removing an iodine atom from the T4 molecule. More than 99.9% of the thyroid hormones in the circulation is bound to three plasma proteins such as thyroxine-binding globulin or TBG, transthyretin or TTR, and albumin. However, due to higher affinity, TBG-bound thyroid hormones account for more than 70% of total bound hormone, which is quantitatively the most important. Furthermore, all three thyroid hormone-binding proteins bind to T4 at least 10 times more avidly compared to T3, which results in almost equal unbound T4 and T3 in the circulation. However, free T3 is significantly more biologically active compared to free T4 due to its affinity to thyroid hormone receptors. Free T4 is the precursor for free T3 and therefore must be converted to free T3 to exert similar biological effects. Additionally, bound thyroid hormones in the circulation are not considered biologically active. The hypothalamic pituitary thyroid or HPT axis maintains normal circulating levels of thyroid hormones, which is dependent on a negative feedback system. When circulating thyroid hormones, particularly T3 falls, TRH gene expression is increased, which results in the production of TRH protein in the hypothalamus and subsequent stimulation of anterior pituitary to produce TSH. TSH then binds to its receptors in the thyroid gland and stimulates the synthesis of thyroid hormones. Similarly, Elevated circulating thyroid hormones, specifically T3, acts as negative feedback on both the hypothalamus and anterior pituitary glands to inhibit the secretion of TRH and TSH respectively. This then inhibits the stimulation of thyroid gland and results in decreased synthesis of the thyroid hormones. Malfunction at any stage in the hypothalamic pituitary thyroid axis may lead to thyroid dysfunction. Testing is therefore critical to investigate the pathologies affecting thyroid function. Thyroid dysfunction is one of the leading endocrine disorders which affects an estimated 200 million people worldwide. It can affect people of all ages, from neonates to elderly, and can be caused by a wide range of underlying conditions. The prevalence is more common in women than men, and the frequency increases with age and iodine deficiency. As iodine is an integral component of the thyroid hormones, approximately 2.8 billion people are at risk of thyroid disease due to iodine deficiency. Thyroid function testing is used to distinguish hypothyroidism or underactive thyroid and hyperthyroidism or overactive thyroid from the euthyroid state or normal thyroid function. It's also used in the evaluation of thyroid response to treatment and to monitor patients on medications that affect thyroid functions. Symptoms of hypothyroidism include fatigue, numbness and tingling in the hands, constipation, unexplained weight gain, depression, cold intolerance, low libido, dry skin, puffy face, frequent and heavy menstrual periods. Hypothyroidism can be caused by several underlying conditions, including autoimmune disease, commonly by Hashimoto's disease, thyroid surgery, radiation therapy, thyroiditis, and certain medications. Risk factors include family history of thyroid disease, autoimmune disease, treatment for hyperthyroidism, and radiation to neck or upper chest. Untreated hypothyroidism can lead to complications such as goiter, heart problems, peripheral neuropathy, infertility, birth defects, and myxedema coma. Thyroxine replacement therapy is the mainstay of treatment for hypothyroidism, which is usually lifelong. It is, however, important to determine the cause of hypothyroidism to evaluate whether treatment is necessary. Symptoms of hyperthyroidism include palpitation or rapid heart rate, feeling shaky and or anxious, unexplained weight loss with increased appetite, diarrhea, vision changes, thin, warm and moist skin, swelling and enlargement of the neck from an enlarged thyroid gland or goiter, and irregular menstrual periods. Hyperthyroidism can be caused by Graves' disease, thyroid nodules, thyroiditis, and tumors. Risk factors include family history of thyroid disease, certain chronic illnesses such as pernicious anemia and primary adrenal insufficiency, thyroiditis, and recent pregnancy. Untreated hyperthyroidism can lead to complications such as atrial fibrillation and congestive heart failure, brittle bones, vision problems, discolored or swollen skin, and thyrotoxic crisis. Treatment options include antithyroid medications, radioactive iodine ablation, and thyroidectomy. Thyroid function tests include the measurement of TSH as the first line of investigation alone or in conjunction with free thyroxine and free triiodothyronine. T4 is the preferred test used to assess thyroid status because of its thyroid tissue-specific origin compared to T3. However, T3 can be useful to investigate the etiology of hyperthyroidism caused by Graves' disease versus thyroiditis, as TSH receptor antibodies involved in Graves' predominantly stimulate T3 secretion, resulting in high T3 to T4 ratio. Although more than 99.9% of the thyroid hormones in the circulation are bound to plasma proteins, measurement of unbound or free thyroid hormones appear to be more appropriate as the level of these proteins fluctuate with certain pathophysiologic conditions, congenital conditions, and medications. TSH is a very sensitive marker of thyroid dysfunction, as it's tightly controlled by a negative feedback loop from the circulating thyroid hormones. As a result, a small rise in circulating thyroid hormones leads to a logarithmic suppression of TSH secretion. Measurement of TSH is therefore the first line of investigation to evaluate thyroid function. TSH should be tested when screening for thyroid hormone excess or deficiency based on symptoms or risk factors, when goiter or thyroid nodules are identified, When monitoring uncomplicated thyroxine replacement therapy, prior to and early in the first trimester of pregnancy in women treated with levothyroxine were those with risk factors for thyroid dysfunction. If TSH level is abnormal, FT4 and or FT3 should be added not only to confirm thyroid dysfunction, but also to evaluate and distinguish primary from secondary thyroid dysfunction. Although spectrophotometric methods have been historically used to quantify TSH and total thyroid hormones, laboratories now commonly utilize immunoassay techniques on automated analyzers to quantify TSH and free thyroid hormones. These analytical techniques include radioimmunoassay, enzyme-linked immunosorbent assay, fluorescence polarization immunoassay, and chemiluminescence immunoassay. However, ELISA is the most common method for manual microplate assays, and chemiluminescence immunoassay is the dominant technique utilized in automated immunoassay systems. Mass spectrometry combined with liquid chromatography can also be used to detect and quantify TSH and thyroid hormones with greater sensitivity and is less affected by analytical interferences such as heterophile antibodies. However, it's not widely used in small to medium-sized laboratories as it involves manual preparation and therefore is more laborious, time-consuming, and expensive for a small number of tests. Let's now briefly go through the different TSH assays. The first generation of radioimmunoassay methods had a detection limit of approximately 1.0 milli-international units per liter, which detected only the normal and elevated TSH levels. This was due to cross-reactivity with other glycoprotein hormones such as FSH, LH, or HCG that are structurally similar to TSH. This limited its clinical utility in the diagnosis of primary hypothyroidism and required the use of TRH stimulation to diagnose hyperthyroidism that was characterized by an absent TRH-stimulated TSH response. However, the sensitivity of TSH assay was improved by tenfold with the second generation of radioimmunological methods that utilized a combination of poly and or monoclonal antibodies targeting different TSH epitopes in a sandwich format. This also reduced cross-reactivity and improved sensitivity and specificity. The development of third-generation immunometric assays that use non-isotopic signals achieved a sensitivity of less than or equal to 0.01 milli-international unit per liter, which allowed not only to determine the lower TSH reference interval, but also detect and distinguish between varying degrees of hyperthyroidism without the need for TRH stimulation. These third-generation immunometric assays use signals such as enzyme, fluorophores, chemiluminescence, and bioluminescence molecules. The current TSH methods are immunochemiluminometric assays which are widely used in automated analyzers. Let's now briefly go through the principle of one variation of chemiluminescence immunoassay method, which is a two-step sandwich immunoassay that uses magnetic microparticles to measure TSH. In the first step, the anti-TSH antibodies coated on the surface of the magnetic microparticles bind to the TSH from the sample and immobilize it on a solid surface. The mixture is then washed under a magnetic field which allows the removal of unbound materials. A secondary anti-TSH antibodies labeled with acridinium conjugates is added which bind to the immobilized TSH, forming sandwich antigen antibody complex. Pre-trigger containing hydrogen peroxide and trigger solution containing sodium hydroxide is added, which results in a chemiluminescent reaction. This is because the acridinium conjugate independently emits light in the presence of hydrogen peroxide and sodium hydroxide, which is measured as relative light units. The signal produced is proportional to the concentration of TSH present in the sample. Over 99.9% of thyroid hormones are bound to plasma proteins, and only a fraction of T4 and T3 freely circulate in the blood. There is a constant equilibrium between the protein-bound and free thyroid hormones. As a result, the concentration of these plasma proteins affect the concentration of thyroid hormones in the blood. Although both total and free thyroid hormones can be detected and quantified in the laboratory with similar diagnostic accuracy, certain medications, pathophysiological conditions, and congenital conditions that affect thyroid hormone protein bindings make measurement of total thyroid hormones inappropriate for many individuals. As a result, Measurement of free thyroid hormones over total hormone testing is considered most clinically relevant. Furthermore, the hypothesis of the free hormone, which states that only the unbound fraction is available to reach target organ and exert biological functions, has resulted in greater interest to measure free thyroid hormones. Whilst TSH is a superior and sensitive screening test for thyroid dysfunction, measurement of FT4 in conjunction with TSH is useful to differentiate between subclinical and overt thyroid dysfunction, to evaluate secondary hyperthyroidism and hypothyroidism, non-thyroidal illness syndrome, and in patients who have been treated for thyroid dysfunction. Measurement of free thyroid hormones fall under two categories: direct, which involves separation of free from protein-bound hormones, and indirect, by either calculating a free hormone index or using immunoassay techniques to estimate free hormone concentration. The direct measurement methods require physical separation of free from protein-bound thyroid hormones by equilibrium dialysis or ultrafiltration prior to direct quantitation. Once separated, the free hormones can then be quantified by liquid chromatography mass spectrometry or immunoassay techniques. Although this is the gold standard method, and when combined with liquid chromatography mass spectrometry can overcome many limitations of immunoassays, it's technically challenging, more expensive, time-consuming, has longer turnaround time, and is therefore not practical for routine testing in clinical laboratories. On the other hand, the indirect estimation of free thyroid hormones can be obtained by either calculating a free hormone index or via immunoassay techniques based on one- or two-step formats. The free hormone index is a mathematical calculation that corrects the total hormone result for the binding protein, primarily thyroid binding globulin or TBG. This requires two separate tests. First, measurement of total thyroid hormones, and a second test to assess the binding protein concentration using a direct TBG immunoassay or T3 uptake test. Although this is now superseded by immunoassay methodologies, free index hormone remains a useful confirmatory test when binding proteins are abnormal and in the diagnosis of central hypothyroidism. Immunoassays are widely used on automated laboratory analyzers and can be based on a one-step or two-step approach. They are suitable for high-throughput laboratories due to their rapid results turnaround time. There are four commonly used immunoassay formats to measure free thyroid hormones, and they include one-step labeled hormone analog, one-step analog with two incubations, two-step labeled hormone analog, and one-step labeled antibody approach. The first one-step approach uses a labeled hormone analog which competes with FT4 from the sample for binding sites on anti-hormone antibodies coated on a solid surface. The unbound constituents are then washed, and the labeled hormone analogs emit signal when bound to anti-hormone antibodies, which can be detected and quantified. The signal produced is inversely proportional to the concentration of FT4 from the sample. The second one-step approach uses a labeled T4 antibody and involves two incubations. In the first incubation, the labeled T4 antibody is mixed with patient sample, and FT4 from the sample bind to the labeled T4 antibodies. Biotinylated T4 and streptavidin-coated microparticles are then added in the second incubation, where the biotinylated T4 binds to the unoccupied labeled anti-T4 antibody from one side and to the streptavidin via biotin from the other side, forming a complex which is captured on a solid surface. The unbound constituents are then washed, and the label on the anti-4 antibody emits a signal which is detected and quantified. The signal is inversely proportional to the concentration of FT4 in the sample. The two-step assay, also known as back titration, uses anti-T4 antibodies that are immobilized on a solid support. In the first incubation phase, patient sample is mixed and FT4 from the sample bind to the fixed anti-T4 antibodies in a manner that the equilibrium between the bound T4 and FT4 in the sample is not disturbed. The unbound constituents are then washed away, and labeled FT4 conjugates are then added to bind to the unoccupied anti-FT4 antibodies binding sites. The mixture is washed again to remove any unbound constituents, and the signal from the bound labeled FT4 conjugate is measured, which is inversely proportional to the concentration of the FT4 in the sample. Another one-step approach uses immobilized T4 analogs that compete with FT4 from the sample to bind to the labeled anti-FT4 antibodies. A wash step is performed to remove any unbound constituents, and signal produced from the labeled anti-FT4 antibody is detected and quantified. The signal is inversely proportional to the concentration of FT4 in the sample. FT3 is part of the thyroid function test panel and is measured along with FT4 when TSH level is abnormal. Although FT3 has limited utility in the diagnosis of hypothyroidism, it is useful in the diagnosis of hyperthyroidism and to determine the severity of hyperthyroidism. FT3 testing is also useful to evaluate the etiology of thyrotoxicosis and differentiate between Graves' disease versus other thyroiditis such as subacute or painless thyroiditis. This is because the antibodies involved in Graves' disease predominantly stimulate the secretion of T3, and thus patients with Graves' disease present with elevated T3 to T4 ratio. Furthermore, some patients with low TSH may only present with elevated T3 and normal T4 or free thyroid hormone index, and therefore inclusion of FT3 in the thyroid function test panel is useful. Additionally, FT3 is also helpful to evaluate thyroid hormone abnormalities in patients with certain acute non-thyroidal illnesses and other conditions that affect the activity of the deiodinase enzymes involved in the conversion of T3 from FT4. Free T3 is measured using the same analytical methods, and I am therefore not going to repeat. However, I do have a separate video on immunoassays in which I explain the principle of the various immunoassay techniques, and I highly encourage you to watch this as numerous analytes are measured by immunoassays. The link is in the description below. Let's now look at a flowchart that shows how TSH and thyroid hormones are interpreted. A normal TSH result in a setting of low suspicion for thyroid disease usually excludes thyroid dysfunction. This is because symptoms of thyroid dysfunction, particularly hypothyroidism, are non-specific, and TSH is often used as a screening test in a wide range of clinical presentations with low pretest probability for thyroid disease. However, if there is high suspicion for thyroid disease, TSH should be used in conjunction with free T4 and/or free T3 to exclude thyroid dysfunction. TSH alone may also not be useful in central hypothyroidism, pituitary resistance to thyroid hormones, and in acutely ill patients. Let's now look at the left-hand side of the flowchart. If the TSH is suppressed, measure FT4 and FT3. FT4 and FT3 above the reference interval is diagnostic for primary hyperthyroidism, which means that the problem is in the thyroid gland. In this case, further tests such as TSH receptor antibodies or TRAPs or thyroid-stimulating immunoglobulins or TSI can help determine the cause of primary hyperthyroidism. For instance, positive TRAP or TSI support a diagnosis of Graves' disease. Thyroid scintigraphy or thyroid scan may be considered to distinguish between Graves' disease, toxic nodules, and thyroiditis if the TRAP test is negative or there is diagnostic uncertainty. Basically, the differential diagnoses include Graves' disease, thyroid nodules, and thyroiditis. A mildly decreased TSH with normal FT4 and FT3 suggests subclinical hyperthyroidism, non-clinical illness, or interference from medications. It's recommended to repeat TFTs within 3 months and may require further investigations. Low TSH with low FT4 and/or FT3 may indicate secondary hypothyroidism, which means that the problem is outside the thyroid gland. Differential diagnoses include pituitary tumor and previous pituitary surgery or radiotherapy. TFT should be repeated to assess trend, and if persistently low, patients should be referred for further investigations. Let's now look at the right side of the flowchart. Elevated TSH with low FT4 is diagnostic for primary hypothyroidism. Differential diagnoses include iodine deficiency, Hashimoto's thyroiditis, and previous radioactive iodine or neck surgery. A repeat TFT, an antithyroid peroxidase antibody or anti-TPO, should be performed. Patient should be treated with levothyroxine, which is a synthetic thyroid hormone. Elevated TSH with normal FT4 indicates subclinical or mild hypothyroidism. Anti-TPO antibody, repeat and monitoring of TFT should be performed. Patient should also be considered for levothyroxine therapy. Elevated TSH and elevated FT4 is an unusual pattern, which may indicate analytical interference. However, it may also indicate TSH secreting pituitary adenoma, thyroid hormone resistance, thyroid replacement, and medication side effects. TFT should be repeated to assess trend, and further investigations may be required. TSH reference intervals are age and population specific and vary with conditions such as pregnancy. These reference intervals are just a guide and may vary between different analytical methods and laboratories. It is recommended that TSH reference intervals should be determined based on the 95% confidence limits of log transformed values obtained from a minimum of 120 selected healthy individuals who have been rigorously screened for normal thyroid function. These individuals must be negative for thyroid autoantibodies such as TPO antibodies or thyroglobulin antibodies and have no personal or family history of thyroid dysfunction, as well as have no palpable enlargement of the thyroid gland and not be taking any medications. Whilst immunoassays can be automated and provide rapid results turnaround time, they are susceptible to analytical interferences which may lead to falsely elevated or reduced test results. To this end, the results must be interpreted with caution and in conjunction with patient's history and other examinations. Some of the immunoassay analytical interferences are as follows. Serum constituents such as increased hemoglobin, bilirubin, or lipids may affect measurement signal and cause falsely elevated results. The acceptable levels of these interfering substances are specified by the manufacturer during method validation and confirmed by the pathology laboratory during method/analyzer verification. Certain drugs such as aspirin, furosemide, phenytoin, estrogen, androgens, glucocorticoids, and the like may falsely increase or decrease test results. Heterophile antibodies are polyspecific endogenous antibodies produced against animal immunoglobulins and other poorly defined antigens. These can interfere with immunoassays and produce false positive or negative results. Biotin is a water-soluble B vitamin, which is found in some foods and multivitamin supplements. It's also used in the treatment of multiple sclerosis, nail disease, and hair growth. Biotin is widely used in immunoassays, and samples from patients on high-dose biotin may therefore interfere with the assay and lead to erroneous results. Pregnancy and conditions such as congenital thyroid binding globulin excess or deficiency and familial dysalbuminemia and transthyretin-associated hyperthyroxinemias can affect the levels of thyroid hormone binding proteins and lead to misleading results. A little more on heterophile antibodies. These antibodies can affect antigen-antibody complex formation in immunoassays and lead to erroneous results. As you can see in the diagram, a true positive result is produced when the capture and secondary antibody bind to the antigen of interest and form antigen-antibody complex, which is then measured. However, in a false positive scenario caused by endogenous antibody interference, the complex between the capture and secondary antibody is formed by the endogenous antibody without interaction with the antigen of interest, thereby producing a false signal. A false negative result, on the other hand, is produced when the interfering endogenous antibodies bind to the capture and secondary antibody which occupy the binding sites and prevent the antigen of interest to interact with the antibodies in the reagent, thus producing a negative signal. Other antibodies, such as anti-ruthenium and anti-streptavidin antibodies, may also interfere with immunoassays that utilize ruthenium as a signal molecule and streptavidin in the reagent. That's it for this video, and thanks for watching. If you've gained any value, please consider subscribing to the channel, like and share the video, and comment for a constructive discussion.